Thanks, Brian. I'm sorry I could not be there in person, but we certainly did not want to miss this chance to tell you about our CLINEX project from last year's CPR pre-clerkship module. Now, our goal was to provide the students with an early, real clinical experience, because educational theory seems to imply that's the best for learning. And there's a couple of components to this. One is engagement, the other is opportunity. And opportunity comes from a couple sources. The most important one is are the patients themselves, and having to care for them provides an immediacy and an authenticity that's critical. And having a physician facilitator and peers in the room also helps provide support. As far as engagement, you have to recognize the learner's needs and respect them, point out the relevance of the science that they're studying in class, and challenge them a little bit, get their emotion up so they retain the information better. Now the challenges facing us, as you can see, we have 174 learners, a compressed calendar that's organ-based. Now we do have some faculty, which are great, but we don't have enough of them. So one solution we experimented with was the clinical exercise, or CLINEX, where we have students in groups of 40 come to a real, regularly scheduled heart failure clinic for a 2-hour block. And they get a great real patient experience with only 4 faculty and 6 patients. And we'll walk you through how each group does. What we'll start with is just showing you the lobby of the cardiology clinic. You can see everyone is very eagerly awaiting their instructions. They were told to be prepared to evaluate a patient with heart failure. And when they got there, they had to reach into a big golden bag and randomly draw a card saying the component of the history or the physical exam they were going to do. All major elements are shown there. And then on the flip side of the card, you can see their group assignment. And each group had all the major history and physical exam elements. Now once they drew their card, they were split up. 3 of the groups went to go see their patient with their facilitator, real patient, real encounter, while the other 3 groups joined together and had a didactic session on heart failure with Dr. Heeman and reviewed the echocardiograms of the patients they were seeing that day. After about an hour, everything switched, and the didactics group went to see their patients, and then the groups that just finished up with their patients went on to have their didactic lecture and review data on the patients they had just seen. The whole thing took about a little more than 2 hours. Now the assignment portion had 2 parts. The first part was kind of different, and this was over the next couple of weeks, the student had to videotape themselves presenting to the camera their patient story as if the camera was the supervising physician. And since everyone has a smartphone or a webcam, this actually worked out pretty well and was easy to do. And because students got to look at themselves and practice before they hit the submit button, there was some reflection built in there. And here's an example coming up.
My patient is an 85-year-old Asian female who presents to the clinic with a complaint of gradually increasing weakness.
And the students did a great job with this. We had provided them with a behaviorally anchored rubric. This helped them organize their presentations and learn the process of presenting a patient story, which is so critical when they hit the clerkship year. Videos were posted on YouTube, so it required no computer infrastructure here, and they could be posted securely.
Hello, sir. I apologize for having to pull you away from the party. However, I think it's critical that we discuss this patient I saw earlier today in clinic. So there was an 88-year-old male who came in for congestive heart failure follow-up appointment, and it sounds like over the past 2 weeks he's been having some increased shortness of breath upon just daily household activities, as he can barely walk more than a block without just having to stop and catch his breath. He's so short of breath. As well, he's had some increase in weight gain, around 20 pounds over the past month or so. He denies any chest pain, denies any fever.
As you can see, some students had fun with it even though they were under no obligation to do so. All the patients were de-identified, and the scoring rubric said they wouldn't get any points if they mentioned any patient information,
Medical
and we
history is
had no
significant for cardiac
HIPAA or
and
other
vascular
privacy
disease. He's got
problems.
hypertension.
This is a 58-year-old Caucasian male with a
Technical
history of myocardial
problems
infarction.
like
He
this
opened
surprisingly
in
were low,
1992
less than
presenting with a complaint
2%.
of
And even when we
quote-unquote
had
severe
them,
right shoulder pain
they were pretty
beginning
readily
approximately 40 hours ago.
correctable.
Expiratory crackles noted in the middle and lower lung fields. The heart sounds were distant with faint S1 and S2 at PMI. 2+ pitting edema bilaterally was also noted on the lower extremities, as was gynecomastia. Per the cardiology fellow, the most recent EKG and cardiac enzymes did not suggest that the latest presentation was a myocardial infarction, which is good news. So, in summary,
I was really impressed with the student performance. Now, the second part of the assignment was to write a brief reflection, and that was it. It was very open-ended. I didn't expect much, but I was impressed with how much the students actually wrote and how the themes in their writing touched on those elements from educational theory that I began with this morning. As far as relevance, it seemed to really tie in the basic science learning that they were doing in the classroom, and it also inspired them to study harder so that they would be ready for independent practice when the time came. And you can see some of the comments here. We touched on some emotional nerves. I think that seeing a patient that was frail, suffering from the side effects of multiple medications, really left an impression. Having to contribute to the care of the patient in a real appointment also was intimidating but inspiring. And making the video was uncomfortable for some, but they liked getting to see how they present and how they're perceived by others. Authenticity related themes was the most common. A lot of it had to do with real physical exam findings, heart murmurs, edema, clubbing. They were amazed at how unscripted and complex real patients were as compared to the simulation center. Being able to go through a patient's clinic visit with their peers and guided by a physician facilitator also had elements of that peer support. And learner satisfaction was very high, as you can see here. High yield, extremely valuable, most rewarding experience at USU. Many students requested more frequent CLINEX type exercises, noting that they learned better by watching and doing, and they also liked the combination of didactics and a real patient in the same afternoon. In terms of some limitations, the sequence of patients versus didactics varied, and also when a patient had family members with them, the rooms could get a little crowded. And we were also reminded how critical it was to have the physician facilitator keep the interview and exam on pace. Now, one thing before we close, through a quirk in the schedule, we may have some potential outcomes. Some students had a simulation center test with a standardized patient with chest pain after their clinical exercise. And that week, some people had their testing done having not had the clinical exercise. And as you can see here, students who had had the CLINEX experience performed better in both the history and physical exam, this clinical skills portion as graded by a physician faculty member, and they did better in the patient communication piece as graded by the standardized patient. Both were statistically significant, and the effect size was very good as well. Now, this is just an association, not causation, but it's very interesting. So in summary, whenever evaluating a new educational innovation, there's a few things to look at. Reliability, we still have some work to do to establish that. But as far as feasibility, we were able to support a large number of learners with limited faculty, with no new infrastructure at no cost. And as far as validity, given this association with improved performance at the simulation center, again, that's an interesting area for further exploration. And this was all in addition to the high learner satisfaction. So I want to thank you again for your time today. I want to thank Dr. Heeman in advance for handling questions about our project. In terms of future directions, I know Dr. Neubauer is expanding this initiative into the dialysis center, the emergency room, and other clinical venues. And finally, I want to thank the patients, nurse, and clinic physicians, as well as our students for participating in this project. Thank you.